Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our experts to talk about all things menopause. From managing symptoms to treatment options, we've got you covered. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event, especially since we received over 800 questions. So thank you again for your interest and engagement. And finally, due to hospital and university guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Robin Fay with gynecology, Dr. Rebecca Jackson with gynecology, and Dr. Shailaja Nair with primary care. Well, again, thank you all so much for joining us. I know we have a lot to get to tonight, but before we dive in, I'll have each of you give a minute or two, say hello, and provide a little background information about yourself. So Dr. Fay, we'll go ahead and start with you. How are you doing this evening?
Great, thank you. So I'm a GYN who is a certified menopause practitioner. I stopped practicing OB about 10 years ago. I was the second medical doctor to become a certified sex counselor in the state of Pennsylvania. And I support patients of all ages for their sexual and menopause concern. And I take care of patients for pelvic pain, vulvodynia, and for all of their sexual health disorders, for menopause, aging, and sexual cancers. I also have a specialty in gynecologic derm disorders, and I also have the pleasure of taking care of trans patients and also LGBTQ patients.
Thank you so much
for inviting me to talk tonight.
Yeah, absolutely. I know, as we said, we have a lot to get to. But next we will turn to Dr. Jackson. Dr. Jackson, thank you so much for joining us this evening. How are you?
I'm great. Hi, everybody. I'm Rebecca Jackson. I am a general OBGYN. I see both OB and GYN patients at Jefferson Center City. I am also a certified menopause practitioner and have been since 2014. And I take care of patients of all ages, all types, with a slight focus towards menopause.
Okay, well, thank you so much. And last but not least, Dr. Nair, how are you doing this evening?
I'm doing great. Thank you, Sarah. It's such a pleasure to be here this evening to discuss this very important topic on menopause. So hi, everyone. I am Dr. Shailaja Nair. I am an associate professor in the Department of Medicine here at Thomas Jefferson University. I'm an internist. I specialize in women's health. My areas of expertise are polycystic ovary syndrome, metabolic syndrome, and obesity. And I've been practicing since 2006. I do wear a lot of administrative hats here at Jefferson. I'm the director for the Jefferson Women's Primary and Specialty Care. I'm the director of Women's Health Education and the director of Integrated Practice in Women's Health. Again, it is my pleasure to be here today to answer your questions and address your concerns on menopause with my colleagues, Dr. Jackson and Dr. Fay. Thank you.
Well, thank you so much. And as we said, we received quite a lot of questions. So let's go ahead and just dive into our discussion for tonight. Okay, so the first question is a two-part question. So Dr. Jackson and Dr. Fay, can you help us with talking about what exactly is menopause? Can you discuss the symptoms that people may experience, hot flashes, weight gain, brain fog, low sex drive, and others? So whoever wants to start.
Sure. Menopause is defined as having no period for 12 months with no other obvious cause. It is a natural, normal process, but sometimes the symptoms don't feel natural or normal. The symptoms of menopause typically start years before the final menstrual period. This confusing time leading up to menopause is often called perimenopause. The most common symptom is hot flashes. These are thought to be caused by the drop in estrogen levels that happen in this time period. People can experience an intense sudden wave of heat, often accompanied by sweating and increased heart rate. When these occur at night, they interfere with sleep and can be called night sweats. Hot flashes and night sweats, which can also be called vasomotor symptoms, can lead to sleep disturbances and irritability. The drop in estrogen can also affect the tissue in the vagina and cause vaginal dryness, which might feel like an itchy or burning feeling and cause pain during sex. Weight gain and brain fog are very common complaints during perimenopause, though they're not as clearly related to the drop in estrogen levels that happen in this time period. I don't know, Dr. Faye, if you want to go on.
Absolutely. So the average age of menopause is 52, and approximately 25% of women are just going to stop having their period. But remember, it's going to be a bell-shaped curve. So there are going to be people who are going to stop having their periods earlier. And I can tell you that I have the oldest patient in my practice is 74, still having a regular period. 25% of women are going to have no symptoms at all. And about 75% of women are going to have some symptoms. Some people are going to have some symptoms that come and go, and other people are going to be able to write their own book of symptoms. Some people are going to have some minimal symptoms, and some people are going to have every symptom under the sun. The perimenopausal symptom can be short for some people, and for other people, it can go on till they're 80, unfortunately, and for a long time. So we're all individuals, and so are our transitions. And so hopefully we can spend 1/3 of our lifetime postmenopausal. So just remember that menopause is really considered just 1 year of your lifetime. And that's just the 1 year in which you don't have periods. You transition to menopause, and that can start early, and that can be when you're still having periods. You have 1 year when you are truly considered menopausal, and then you're postmenopause, and hopefully you'll spend a good time of your life postmenopausal. Also remember, during that time, we have to consider things like bone health. And that's so important because the first 5 years that you're without your period and your periods are changing, you can lose up to 20% of your bone. So besides all of the symptoms that we all think about and worry about and have concerns about, we also have to think about bone health. So we actually peak bone at about 30 years of age. So one of the other things that we all think about and need to think about is calcium and vitamin D. And therefore, in terms of important things to worry about, that's one of the other things. The other thing, as a sexual health physician, that I always talk about to my patients is remember about orgasms. Orgasms change. Your sexual health is so important too. So when I talk to patients, besides when we talk about vaginal dryness and everything else, I always try to remind patients and make them not be concerned about the fact that they are going to have changes in their orgasms. They might lose them completely, which can be a problem, or that they're just going to change. So they might all of a sudden notice that the intensity is different and everything else. So not having periods after years of having awful cramps and bleeding which is great for a lot of us, but there's so many changes that can occur. So that's a lot of the changes that can occur with menopause.
Well, thank you so much for both of you walking us through that. And yeah, a great call out about bone health too, something that many people don't take into consideration. So thank you for that flag there. Okay, so our second question here, a popular question we received, is how long does menopause last? When does it end? And does it get better? I know you kind of mentioned this a little bit, but Dr. Faye, do you mind just going into this a little bit more?
Sure. I mean, remember that in terms of, as I said, that you can have what's premature ovarian failure, or we talk about, so somebody can be really young when it goes on. And as I said, it's going to be a bell-shaped curve, just like you have with menarche. We can have people remember at the other end of the spectrum, people as early as 8 and as late as 18 having their period. The same thing happens with menopause. So you can have people young going through the change, and you can have people older. We talk about the average age being 52, but as I said, we can have people much older going through it. But the truth of the matter is that there's probably that rocky time where your hormones are like a lava lamp for probably about 5 to 7 years for most people. But we always used to think that your hot flashes and things would end. But unfortunately, for some people, they can even still experience them even later in their 70s and 80s, but they're not as bad. So there is that really harder time, which we talk about, that estrogen window, which is probably those first 10 years from the time of your periods disappearing and getting irregular to them totally being gone. And that's probably the first 10 years. And that's why we talk now about hormone therapy for those 10 years, talking about that's a safe zone for you to start your hormone therapy, because we have that estrogen window, which is that first 10 years.
Okay, thank you. Dr. Jackson, anything to add there?
Not to be redundant, but I really just want to emphasize how it's different for each person. And everybody's experience is going to be different. Most people will start to have some symptoms, 4, 5, 6, 7, 8 years before their final menstrual period. And it can continue until the same amount of years after their final menstrual period. Some people won't have any symptoms at all. So it's hard to, predict for any person what it's going to be like until you're there.
Absolutely. All right. Well, thank you for that call out. Okay, our next question here. This question is for all of you. What are the treatments for menopause? And we hear a lot about hormone replacement therapy, as Dr. Fay just mentioned. So can you just discuss the pros and cons? Who is a good candidate, and even more? Dr. Nair, we'll go ahead and start with you.
Sure, yeah. So as our doctors here mentioned earlier, the average age of menopause is around 51, 52 years. And the average lifespan of a woman in the US is around 77. So as you can imagine, women spend about 30 to 40% of their life in menopause. So during this time, during the perimenopausal phase, which can extend about 2 or 3 years before a person stops having their cycle, and into menopause, women experience a host of symptoms ranging from hot flashes, night sweats, the vaginal symptoms due to lack of lubrication, as Dr. Fay and Dr. Jackson mentioned, with vaginal dryness, painful intercourse. Patients may experience sleep disturbances as well, change in mood. They may notice skin changes, and they may notice bone aches, and so on and so forth. So interestingly, most of these symptoms, almost all of them, respond to menopausal hormone replacement therapy. However, hormone replacement therapy has been approved only for menopausal hot flashes and night sweats. We call them vasomotor symptoms, and for genitourinary symptoms of menopause, which include the urinary symptoms, urinary frequency, frequent pain with urination, frequent UTIs, which is urinary tract infections, or pain with intercourse or vaginal dryness. And the reason is this, because prior to 2002, we were prescribing menopausal hormone replacement therapy for all these indications. And in 2002, the Women's Health Initiative study report came out. So this was a huge multinational, multi-center trial with over 160,000 postmenopausal women. This was looking into, it was a 15-year-long study looking into the effects of menopausal hormone therapy in protecting against the heart. So that was the reason they were doing it, to see whether it protected against heart, reducing heart attacks, heart strokes, reducing colorectal cancer, breast cancer, and reducing bone osteoporosis as well. But the study was prematurely stopped in 1992, and this is because the study arms, which is the arm of patients who received the menopausal hormone replacement therapy, were found to have increased incidence of heart attacks, strokes, and breast cancer. So they did see that it does protect against colorectal cancer, and it does protect against osteoporosis. So that's where the revision happened in terms of who gets prescribed the menopausal hormone replacement therapy. So since then, we have had extension studies for the Women's Health Initiative. And the study basically, from the extension studies, we know that the women who developed these adverse events were mostly were women over the age of 60. So that's why, as Dr. Jackson and Dr. Fay mentioned, the recommendation is usually to start the menopausal hormone replacement therapy within 10 years of menopause or less than age 60. And we try to keep patients on the menopausal, in most cases, for a shorter period of time, usually around 5 years or so, and then transition them on to non-hormonal treatments like SSRIs or new gabapentin, or there are other medications that are approved for this. So in terms of vaginal symptoms, the genitourinary symptoms of menopause, the treatment usually is local. The preferred treatment is using local creams and ointment, estrogen or tablets or creams. And these are actually very safe because the systemic absorption or absorption into the bloodstream is very little. And so these can be used indefinitely. They can be used long-term as well. So when we start in terms of starting the hormone replacement therapy, we usually start with low dose estradiol, either oral forms or the patches or creams, and then titrate the medications up. But in patients who have really bad symptoms in terms of hot flashes and night sweats, we tend to start the patient at a slightly higher dose of the medication. So contraindication to using the menopausal hormone replacement therapy includes a history of heart disease, history of strokes or mini strokes that we call TIA, history of active liver disease, or vaginal bleeding. Abnormal vaginal bleeding is also a contraindication to using the menopausal hormone replacement therapy. So for patients who are in the perimenopausal age group, 40 to 50 years of age, and who suffer from hot flashes, night sweats, oral contraceptive pills can be used instead of menopausal hormone replacement therapy. And the usual practice is to transition these patients at age 51 or 52 to menopausal hormone replacement therapy if they still need it. And as our doctors mentioned earlier, many patients usually have symptoms for a few years, but some of them, it's very individualized because each person is different. So some patients may have symptoms just for a couple of years, whereas other patients may continue to have symptoms for many years after menopause. So it has to be individualized.
Okay, well, thank you, and appreciate you sharing that background information as well. I think that's very helpful for the audience, so thank you. Okay, Dr. Jackson, anything to add?
I would just echo a lot of what Dr. Nair said. And I just, just to back up to the basics. So hormone therapy for menopause is typically made up of two hormones, a form of estrogen and a form of progesterone. And that's for anybody who still has their uterus. For people who had a hysterectomy, they can take just estrogen alone. And that's because estrogen alone can have negative effects on the uterus. So the progesterone is to protect the uterus, and the estrogen is to treat the symptoms. Hormone therapy is definitely the most effective treatment for symptoms of menopause. And I think Dr. Nair, talked about how well it works for that. There are non-hormonal treatments as well. And for some people who can't take hormone therapy or who want to avoid hormones, there are some medicines that are made for other reasons that have been shown to decrease hot flashes and night sweats. And that's, like she said, like low doses of antidepressants or a medicine called gabapentin or clonidine. And there's actually a new medicine that has been, and I'm not here to market any specific medicine, but I just think it's interesting because it's the first medicine that I know of other than hormones that was looked at specifically to treat symptoms of menopause. And it works on some of the receptors in the brain, which work on the thermoregulatory system. So it's exciting that there's a brand new FDA-approved medicine for hot flashes and night sweats for people who can't or don't want to take hormones.
Absolutely. And interesting to hear some of those other options. So thanks. Okay. And Dr. Fay, anything else to add to this discussion here?
Yes, there has just been a most recent article that came out actually as of May of this year that actually showed that you actually can continue on hormone therapy actually after the age of 60. So people who had started on the hormone therapy in their early 50s because of hormones no longer need to stop it after 5 years. If they're doing well and they are still people who have no contraindications to being on hormone therapy, they can actually stay on it now after the age of 60. And that's just an article, and that's actually been adjudicated from the Women's Health Initiative. So they actually have done more studies to show that you still stay on it and you still go on it just because of symptoms, not because it's not been approved and it has been not shown again, because of cardiac disease or anything else. But if you are continuing to treat someone for bothersome symptoms and someone at the age of 60 now says, I want to stay on my hormone therapy, she's safe to stay on it. So that's really great data that we just have come up and found. So it's wonderful. So, because I have patients who say to me, if you take me off my hormone therapy, I'll slit your throat. So they love it. They stay on it. They look great. They feel great. Their bones are doing well. And so I'm keeping them on it and we have the data now to show it, which is great information.
Yeah, absolutely. Very exciting. All right. Well, thank you for sharing that. Okay, we'll dive into our next question here. This one is for Dr. Nair. How can someone prepare for menopause and what can they expect?
Sure, yeah. So during the menopause transition and into menopause, women have a host of symptoms, and some of these symptoms are due to decline in estrogen. So estrogen levels going down cause a lot of these symptoms, but many of them are also due to a combination of aging as well, the aging process, and due to life changes as well, which can cause some of those symptoms. So for example, when we talk about estrogen deficiency, the most common ones, as we talked about, mentioned several times here, would be the vaginal dryness, the urinary symptoms, the hot flashes, and night sweats. But the estrogen deficiency can also cause redistribution of fat to abdominal area and to the visceral organs. This results in insulin resistance, and it can lead to prediabetes and diabetes risk. And it also causes weight gain after menopause. This is why women find it harder to lose weight after menopause. So in addition to this, what happens is there is something called sarcopenia, or loss of muscle mass after menopause. And muscle is what sets our metabolic rate. This is what helps us lose weight. So once we have loss of muscle mass in menopause, it becomes much harder for us to lose weight. And I think the third part about it is that, the metabolic rate or the metabolic process slows down in menopause, as is with age. So then it basically adds on to other issues that we have with the weight loss. So with the menopause, usually women tend to gain about a pound per year on an average. So over the course of several years, 20 to 30 pound weight gain in menopause is pretty common. And this is because of, several of these factors. The other part of it, and I think Dr. Fay mentioned this, is the bone health, or Dr. Jackson mentioned this, is the bone health. Very, very important to think about that, because as we age, we lose bone mass. So the bone mass is the strongest in our 20s and 30s. So from age 31 onwards, we start losing 0.5%, 0.5% bone mass every year. And the bone loss is the greatest closer to that perimenopausal age, the year before we hit menopause. That's when we lose the most of our muscle mass. It's 5% per year for a few years, and then it stabilizes again to 0.5% per year. So what this means is that after menopause, there's a very high risk of developing osteoporosis, thinning of the bones, increased risk of bone fractures, and all of these can interfere with quality of life in our menopausal age during that time. So it's very important to be aware of that and help protect our bone health. Another thing we need to remember is the cardiovascular health, or increased risk of heart disease that happens as we age. In menopause, there is increased risk of heart disease because of increased LDL, or the bad cholesterol level goes up as we age, and that is one of the big risk factors for heart disease. Another factor is reduced pliability of blood vessels. The blood vessels get stiffer as we age because there is no longer the protection from estrogen. And this can lead to hypertension and increased risk of heart disease. And in addition to these, but the good part about it is that almost 70% of heart disease risk can be reduced with lifestyle modification. So that's the good news we have. Now, in addition to this, there are lots of life events happening, kids leaving home, we have aging parents, and so this causes extra stress, aging in workforce. Stress causes increased release of cortisol. That in turn causes increased insulin resistance and weight gain and increased risk of heart disease. So how can we prepare for menopause? There's a lot of things we can do. One of the big things is, of course, diet and exercise. In terms of diet, Mediterranean diet has been shown to really help with weight and with heart, protecting heart. So basically trying to do more vegetables, fruits, nuts, lean fat, lean meat, very important to do that. And because we need protein for our muscles. And then trying to stay away from saturated fat, trans fat, trying to stay away from excess salt, excess sugar is really helpful. The other part of this is exercise. Now, in terms of exercise, it's very important to keep up with our exercise for bone health, for mental health, it also helps reduce hot flashes, and overall for the weight as well. So in terms of what types of exercises to do, moderate intensity exercise, if the recommendation is usually 150 minutes per week. So that comes to around, if you can do 30 minutes of moderate intensity exercise per day for 5 days, that's great. And what do we mean by moderate intensity exercise? It's jogging, or it's brisk walking. It's a form of exercise where you can walk and talk, but not sing. So that's usually a definition of a moderate intensity exercise. Yeah, and we could do, the other recommendation is doing a high intensity exercise. High intensity exercise is excellent. If you're doing that, 75 minutes of high intensity exercise per week is adequate. And by high intensity exercise, we mean jogging or cycling. These are the form of exercises. These are activities where you can talk, but just a few words, that's it, because it's very high intensity. In addition to this, make sure to add resistance training in there. Resistance training is important. These are weights, weightlifting and so on. This is important to build muscles and also for bone health. It helps combat osteoporosis. It helps with weight loss as well. In addition to this, smoking cessation, very, very important. For women who smoke, the smoking is a huge risk factor for heart disease, also for osteoporosis. It worsens hot flashes. Same thing with alcohol, limiting alcohol use, because that can worsen hot flashes. So these are some of the lifestyle modifications that people can do. In terms of supplements, just adding one quick word there for bone health, calcium, making sure that we get 1,200 milligrams of calcium daily, either from dairy or non-dairy sources. Like kale and certain vegetables, yogurt, and so on, have a lot of calcium in them. Adding vitamin D around 800 to 600 units daily as well really helps with the bone health. So I think, there's a lot we can do from our end to help, transition through the menopausal phase.
Absolutely. Thank you so much. That was very informational. Really appreciate it. And also just helpful to hear kind of the awareness aspect of it as well, to then ultimately hopefully lead to prevention. So thank you. Okay, before we turn to our last submitted question, before we go to our live audience questions, just want to say thank you for submitting your live audience questions in the chat. We see them coming through. So feel free to keep submitting them as we're gearing up for an exciting discussion that's live. But for the time being, we'll take one last submitted question. So Dr. Faye, know that Dr. Nair talked a little bit about stress. Can you talk about the anxiety and mental health aspect of menopause?
We know that menopause is associated with a lower quality of life. And that's based on limited, scientific evidence. We know that hormone therapy is not recommended at any age to prevent or treat this. But initiating hormone therapy can basically help in terms of helping. There actually is limited scientific evidence that estrogen therapy has some antidepressant effect, similar to antidepressants. So therefore, transdermal estrogen with progesterone actually can prevent depression in a perimenopausal woman. But estrogen is not government approved to treat mood disorders. So we know that menopause it can be a time of anxiety and everything else. So we kind of do suggest that if somebody is having some issues that, we use hormone therapy, we do use Effexor, we do use some of things to help us with their menopausal symptoms. So it can be used. So it's something to suggest to people, because this is a horrible time. Your hormones are like a lava lamp. They're all over the place, especially during that perimenopausal period. So, you're not going through it alone. And we talk to people and say, please reach out, please talk to your provider, please, this is not a time. You're in that squeeze generation. Usually when you have, ailing parents, your kids are usually in a time when they're either transitioning to college or they're in high school, and times are tough. Work is usually tough too. And so it's anxiety ridden. Your hormones are all over the place at the same time. There's a lot of stress going on and everything else. So sometimes hormone therapy will help. And so it's beneficial.
Yeah, a really important reminder. So thank you. Okay, well, with that, let's go ahead and dive into our live questions. Before we start reading out specific questions here, I do want to say that we've gotten a lot of questions about supplements. So can you please speak at first to this just generally, maybe give a little bit of advice on how to navigate all of the supplement options out there? And whoever wants to chime in, feel free.
There are so many supplements out there. And I think that it's better to talk to a skilled provider before somebody starts using something called Menopause, because Menopause is going to have a lot of different ones in there. And you need to know what is in there, whether it's safe for you to use with what you're already taking. If you have a reaction to it, you don't know what you're having a reaction to. So I always ask people to please bring in the container that they're using or that they have gotten from the health food store or online to see what's in there, because there could be things in there that are not safe to use. There could be things in there that are dangerous to your liver. There could be things in there that just aren't good with what else you're taking. And it's important. So I think that before somebody jumps in to say, oh, it says menopause on there, and it says it's going to help all my hot flashes, all my night sweats, my vaginal dryness, and everything else, go in and talk to a provider and find out, is it a good thing to take? It might be great, but it might not be. And it might be dangerous. It might be liver toxic. Or it might just be something that you shouldn't be taking because of your history of breast cancer, or it might be something that you shouldn't be taking at all, or it could be something you should be taking. So I think it's beneficial to find out. And so always ask a provider first.
And the other thing I would caution people about, I agree with all of that. And additionally, supplements will market, they want to sell to you, and they'll tell you there's a 50% reduction in hot flashes, and they'll sell you a lot of data, but what they won't sell you is any comparison to placebo. And very few of these things have been shown to be better than just a sugar pill. So I would just be careful. For an individual, a supplement might work great, but I would just be cautious about spending a lot of money on these supplements.
Yeah.
I echo what Dr. Jackson and Dr. Fay mentioned here. I think there are so many supplements out there, and I think as women, as we age and we go through menopausal period, we struggle with the symptoms, and we try to pick whatever we can get to help with our symptoms, and sometimes it can be very detrimental. Please do realize to understand that these are not FDA regulated. The medications out there, we do not know what side effects these medications can cause. It may say something on the label. We have no idea what you're getting when you buy them. So please be careful with these supplements and do talk to your doctors before you start taking these supplements.
I had a patient who said that she bought something for vaginal dryness that she was taking orally. And I said, did it have a GPS on there to know to go to your vagina? I mean, it was just like, I don't know why, how it would know that it was going to go there versus anywhere else. It's like, don't buy something just because it says that it's going to work. You don't know. It's like, you have to think about what you're buying and spending all this money for, and that's why it's like, talk to somebody and find out whether it's even going to be worthwhile.
Absolutely. Yeah, I think a resounding message, talk to your doctor. All right. Well, let's go ahead and dive into the rest of the questions. So again, feel free, whoever wants to chime in, go right ahead. But for this question here, this person is wondering, are there any trusted resources aside from your provider? So good question, a follow-up question here. Any trusted resources that you recommend for people to turn to learn more?
Menopause.org. It's the
Exactly.
Menopause Society. And it's a great site that you can go on. So it's menopause.org. It's the Menopause Society that both Rebecca and I got certified through, so it's basically, and they have a patient portal to it. And so I give out the menopause guidebook, which I helped create years ago. And it has all kinds of information for consumer education information in it. And it's wonderful. And it really does give you educated material.
All right. Thank you. That's a great resource. So appreciate you sharing. All right. Our next question here. This person is asking, can you explain what premature ovarian failure or POF is and how this might be different from perimenopause?
It happens in younger patients. So it's somebody who goes through menopause, or really what it is called now is primary ovarian insufficiency before the age of 40.
Okay. All right. Thank you. If anything else either of you want to add, otherwise we can go to the next question.
I mean, it
Okay.
could be either because of either genetics, or it can be because of somebody having chemotherapy, or it's just, because of some kind of autoimmune condition. It's early versus somebody who is in their later 40s going through perimenopause, meaning she's just transitioning to menopause. So it's an earlier form of menopause.
Okay. Thank you. All right. This next question here, we did talk about this earlier, but if we want to dive in just a little bit more, because I know this is a topic of interest, how can stress affect menopause symptoms?
So I can probably start with that. Stress does make, so during as women transition through menopause, if they have a history of depression, it can actually worsen through the menopause transition. And women who have never had depression can experience depression for the first time when they go through the menopause transition. So I think it's important for women to be aware of this. So if they have if they develop mood changes, if they are noticing that they don't feel like going out much, they are having depression symptoms, please reach out to your healthcare provider to discuss this, because there is help. Again, we have great medications that will help with these symptoms, and we have resources that we can provide to guide you through this time. And this is due to the hormonal changes. Estrogen deficiency can certainly cause the depressive symptoms, the mood swings and mood changes, but there are also, as I mentioned earlier, there are several life changes happening during this time as well, which adds on to the stress. This is a time when, we are going through changes. Our body is going through changes. We're going through changes at work. Our family is going through changes. And so it can be a very stressful time. So it's important to be aware of being educated about this and being aware of it, aware of the problems that may happen. I think that's our strongest barrier we have to fight against, the complications and consequences of depressions.
Also, hot flashes can be worsened by
Yes.
by anxiety. I mean, people say, when they're under stress, or that makes their hot flashes worse. So, also that can do it too.
Mm-hmm. A lot to
And
think
it's a
about.
vicious cycle, because then the hot flashes make the anxiety worse.
Right.
Yep.
So it's right. It's just a big circle. Absolutely.
Absolutely. Yeah. Just a reminder again to talk to your provider. Okay. All right. This next question here. Could you talk a little bit about surgical menopause and how that differs from natural menopause?
You just get your symptoms are worsened. That can be somebody who can be, if somebody's 30 some years old who had endometriosis and had her ovaries removed, she's going to have premature menopause. So therefore, that's going to be the person. And let's say it's not endometriosis, because that's going to be a totally different topic. But let's say we have to remove her ovaries. we're going to talk to her about replenishing her body with her estrogen. So we're going to talk to giving her back, because she is going to be abruptly cut off. She's going to be castrated. So it's going to be horrendous for her. We're going to worry about her bone health. We're going to worry about everything with her. So we're about her moods, about everything. And in fact, we have found that women who lose their estrogen early need to be given a higher dose, because of the fact that, you're taking it away from her so much younger. So you're going to give her a larger dose. She's going to be on it for a longer period of time. And in terms of, they're going to be nauseous because they're going to have lost it so abruptly. It's terrible. So you're going to want to put them on a higher dose, and they're going to be on it for many, many, many years. And then you transition them to lower when they would have gone through it at 50 and later.
Okay.
Yeah, and earlier we were talking a lot about that perimenopausal time, that time leading up to menopause, where there's a lot of fluctuating hormone levels, but you have some estrogen throughout that time frame. And with surgical menopause, it's a very abrupt drop in menopause. People tend to have much more dramatic symptoms.
Yeah.
All right. Well, thank you. Okay, our next question here. Is it typical to see changes in bowel patterns with more urgency or frequency during menopause? And is there any recommended treatment to help control this?
I can take that. So yes, definitely there is plenty of data at this time looking at the gastric microbiome, how it changes with menopause. There is something called estrobolome, meaning bacteria in the bowel that produces estrogen. And the estrogen producing bacteria basically keeps the good bacteria in place. So it helps with digestion, it helps with your regular bowel movements and so on. So after menopause, there is basically what happens is similar to most of the other symptoms we had talked about. The lack of estrogen protection makes the bowel similar to that of men, and there is a lot more inflammation that happens after menopause, and there are a lot of bowel symptoms, including development of constipation, change in bowel habits. It could be either diarrhea or constipation, tummy, abdominal pain, nausea, bloating. These are all symptoms that can happen due to estrogen depletion and the gastric microbiome changes.
All right. Well, thank you. Okay, our next question here is talking again about mental health. I know, again, this is a topic of interest. So can you just speak a little bit about, mental health and menopause, such as anxiety, fatigue, and depression, and how would you suggest navigating these feelings?
Talking to a professional, which sometimes means talking to a therapist. Absolutely. Not only talking to your physician, your women's health physician, but also sometimes talking to a therapist, which we encourage you to do. Absolutely.
Yeah, I think, we have great resources at Jefferson. We have psychotherapists, we have behavioral health specialists, we have a great psychiatrist. Most of our patients who are I wouldn't say most, some of our patients who are transitioning through menopause have were bad enough symptoms where I've had to refer them to psychiatric as well, have them involved in the care as well. But most of them do well with our behavioral therapist. We have a behavioral therapist in our office, and she's been a great resource for our patients, because many of this is life-changing life events that are happening, and we have a reason for why they're stressed in addition to the hormone depletion. So the talk therapy really helps. So if I might go back to the previous question, I think I forgot to answer regarding, what can be done with the bowel symptoms and what can people do to help, have normal bowel patterns and so on. So studies basically show, again, something that we discussed earlier, a lot of these can be navigated by dietary modifications and exercise. So diet is a big part of this, eating healthy, cutting down on inflammatory foods, which are your saturated fat, trans fat, fried foods, fatty foods. So again, for this as well, the Mediterranean diet with, healthy, with fruits and vegetables and nuts and healthy nuts and oils are very helpful in creating a balance with the gut flora. So that would be something that would help.
Okay, great. Thank you for bringing back up that question so we can talk about what can be done, and also appreciate sharing those resources too. Okay, next question here. There is a lot of information about estrogen loss, but can you speak about testosterone levels in postmenopausal women?
Testosterone drops also, in addition to estrogen and progesterone, because the ovary also produces testosterone. So it is something as a sex counselor that I do talk about with patients, because testosterone is the well-being hormone. And so sometimes it is a hormone that we do give back to patients. It's not always a hormone that, we give back estrogen and progesterone by way of hormone therapy, but I also do give back testosterone for people who have decreased libido, and it is something that we do.
Yeah, it's not, unfortunately, there's not an FDA approved formulation of testosterone for women in this country. But I agree with Dr. Faye, it's very effective for decreased libido in patients who don't have another reason for their decreased libido after menopause.
Okay, thank you. Can you also talk a little bit about the use of IUD or birth control, which I know was mentioned earlier, but if you could expand on that, during perimenopause?
When someone's still just having irregular periods, so they need birth control, and we're still working with an active ovary, you're not going to put them on hormone therapy. So you're going to put them on a birth control pill. So they're still not postmenopausal. I'm going to use a birth control pill. So that's why, and they're going to get symptomatic relief because they're having some hot flashes, but they're still cycling. So if they're still cycling, you're going to use a low dose birth control pill.
So I would add to that the only contraindications to that age group that we do not use oral contraceptive pill is patients with hypertension, history of migraine headaches, I'm blanking.
Well, if they're a
Smokers.
smoker, they're smokers.
Smoker,
right?
exactly. Yeah, if you're a smoker, you wouldn't use it either.
Right.
Exactly. Thank
So
you.
again, you're going to talk to your provider, obviously, and the provider is going to make those decisions as to what you use, right?
And Sarah, you had asked also about IUD use in this population, and it's something that would be very effective for contraception, but wouldn't help with the symptoms.
Right.
Sometimes I'll use an IUD. Again, we're talking about a lot of off-label uses of things, but
yeah.
sometimes I'll use an IUD for endometrial protection. So people could take just estrogen and have their IUD to provide the progesterone in their hormone therapy.
That's the best. Yeah, that's the
favorite.
best. Love that. Yeah, that's great. That's great.
All right. Well, thank you, Dr. Jackson, for bringing up the IUD as well. Some important information there. Okay. I know migraines, I think, was mentioned. We do have a question here. Any suggestions on how to manage migraines associated with menopause?
Same way you do it any other time. I mean, unfortunately, they're awful, but we thank heavens have some really good treatments. We have, the Nurtex, we have the Ubelvies, we have some things. But again, I like using neurologists to help us out with these things, because you want to make sure that there's no underlying cause and everything else, because, so I like to make sure that there's no underlying cause before I just would treat.
All right. Thank you. Okay, Dr. Faye, this is a question for you. This person is wondering, can you speak a little bit more about how to manage a lack of sex drive?
Well, I usually have a whole discussion with a patient. We go through a whole biosocial medical discussion with a patient, and I usually do a whole counseling session with them, because you want to know whether this is a new onset, whether this is long-standing discussion with them. I do a whole exam with them, and we just go through I go through a whole long thing with them. as a sex counselor, I will go through a whole thing because, is this something to do with everything from religiosity to childhood to your relationship, and so there's a whole long thing that we go through in terms of just, somebody walking in and just saying, my sex drive is down. Is it a new onset? Has it been something that just has happened with menopause? Have you always been were you somebody who was always interested in sex and has just changed? Is it something that, were you always the person who, was the person who said, come here, cute boy, or were you always the aggressor? Were you not the aggressor? There's a lot that goes into the questions that we raise. So, it's not just a simple, my sex drive is down, right? So there's a lot of questions that we raise, and I do a whole discussion with them because we want to know.
Sounds like that could be its own webinar in itself.
You got it. You got it.
Yeah. All right. Well, thank you. Okay, this question here is about blood work. So do you typically recommend any blood work either before or during menopause? And what about measuring hormone levels?
I'm totally against doing hormone levels. I don't know about you guys, but a hormone level can be drawn on two different people, the same hormone level. One person can be symptomatic, one person's not symptomatic, and it doesn't tell you how someone feels. So I like to talk to my patients because hormone levels don't tell you anything about how somebody feels. And so people who draw hormone levels, you can do that for thyroid, you can do that for cholesterol, but it doesn't tell you whether you're having a hot flash or not. It doesn't tell you how dry somebody's vagina is. It doesn't tell you how anxious somebody is. So a hormone level doesn't tell you anything. It doesn't tell you a thing. So I'd rather talk to my patients, and hormone levels don't tell you that.
Yeah, I agree completely. I treat really based on symptoms. And
Yeah.
The other thing is in perimenopause, your hormone levels fluctuate so much that if I checked your hormone levels on 3 different days, you could have 3 different numbers.
Yeah. So when people come in with hormone levels, and forget about salivary levels, right? Salivary levels don't mean anything, right? And so when somebody comes in and says, my so-and-so told me to draw my hormone levels, and I go, oy, please, what am I going to do with these levels? And I just put them to the side and I go, talk to me. Tell me how you are. Tell me how you feel, because that's more important, right? Because there's no hormone level to tell me that you're anxious, no hormone level to tell me you're not sleeping, right? It's so important to know how someone feels. We want to listen to our patients, right? That's what's more important.
Yeah, I completely agree. I don't do that either because again, like Dr. Jackson mentioned, even if you check the levels in the same individual on 2 different occasions, it'll be 2 different levels with perimenopause. So really no point in doing that. So you see a lot of these wellness places where they do urine and salivary testing and they do bioidentical hormone replacement and so on. It really is, it scares me because they are not FDA approved. We have no idea what the patients are getting. They could overdose on the medication or it might be too little. So it really is not safe.
Well, also, what's the difference between an FSH of 90 and an FSH of 45? They're postmenopausal. Like, what does that mean? It doesn't mean anything, right? Yeah.
Some really important call outs. So thank you. All right. Our next question here, can you talk a little bit more in detail about symptoms of perimenopause specifically?
So with perimenopause, usually, the vaginal part of it, the vaginal dryness, vaginal atrophy, urinary symptoms happen later, a little later. So the earlier part of it usually is the hot flashes. That's one of the things that many women complain about, the hot flashes and night sweats. So if patients come in their 40s, early 40s, or even in the 30s and complain of hot flashes and night sweats, the way we approach it is slightly different. So we talked about the premature ovarian failure. So that's where you would do extensive lab for a woman who is less than 40, who is coming in with hot flashes and night sweats, versus a person in her 40s who is coming in with hot flashes and night sweats. Because the first diagnosis always would be that person is probably perimenopausal, and that's why she has it. Although you still have to check your thyroid and prolactin levels, those are two things we always want to make sure that that's not interfering or causing the symptoms, but that's usually majority of them have these symptoms. You may experience the weight gain, like I said, one of the symptoms that many of these women, many of us experience in the mid-30s. It becomes harder to lose weight. The metabolism starts to slow down. Estrogen starts to go down. You don't see the symptoms of it yet, but that does happen where it starts to slow down, and the bone mass starts to slow down. The muscle mass starts to slow down. So it gets harder to lose weight in our 30s itself. The changes that we notice with the skin and hair, that starts early as well. So many women may notice that the skin becomes less elastic because we lose collagen, and the skin becomes a little drier, the hair becomes drier as well, the texture changes, mood swings may start to happen. Perimenopausally, you will notice the PMS symptoms get worse. A few years before menopause, it can get much worse. So a lot of these symptoms can happen in the perimenopausal age group.
But it also happens kind of mid-cycle and close to their period. They're not going to have it every day. So what happens is that I'll always say to a patient, do you notice these more kind of mid-cycle, closer to your period? You're not noticing them every day. You're noticing a few hot flashes, a few night sweats, a few sleep disturbances. Maybe you're getting up more to go to the bathroom, like when you have wine at dinner, not every night, but that's what you're noticing first is perimenopause. And then as you get closer to menopause, then you start noticing them more every day. So the symptoms are not, and and I always say you're noticing your vagina more because you're kind of noticing the dryness a little bit more then you're noticing it, then you start noticing it closer to menopause. Not, all the symptoms don't start noticing every day in the beginning. That's really more perimenopause. Then with menopause, then it's every single day, and even when they're on the birth control pill, that's what they notice. Like the week of their period, that's when they kind of notice the symptoms, more than because they're not on any kind of a hormone. Then that's when the symptoms are more the hot flashes and night sweats.
And then the other big thing that people notice in perimenopause is irregular periods and skipping periods.
Yes.
Right. Right.
And for a lot of people, the symptoms are worse in those months that they skip. So they don't get a period at all 1 month. They have terrible symptoms. Then they get their period back. They're annoyed that they're bleeding, but they feel better because their symptoms are better.
Right. All of a sudden that hot flash went away. They go, oh, and they go, yeah, well, it's because you're going to get your period. You all of a sudden feel so much better. So damn, you got your period and you're crampy, but guess what? You're not having a hot flash anymore. So it's all of a sudden, you got to take one versus the other. Yeah, absolutely.
Yeah, an interesting way to think of it. Maybe not complaining when you have your period next time.
Right.
All right. Next question here. Do you recommend pelvic floor therapy as a way to help vaginal symptoms?
Absolutely. I love pelvic floor physical therapy. I mean, I suggest it when they're in their 3rd trimester of pregnancy, after they deliver. Absolutely. And sure, I mean, not for vaginal dryness per se, because that's not, but when they're starting to have that incontinence and everything else, absolutely. They're my best friends. Absolutely. Wonderful. Wonderful.
Yeah, me too. I send my patients for. So with menopause, what also happens is there is weakening with estrogen deficiency. There is weakening of the pelvic floor muscles, and that's why patients, when they cough, sneeze, they tend to leak. So there's weakness in the muscle. So pelvic floor physical therapy really helps with the symptoms. So in Europe, after vaginal delivery, baby, after a woman has a baby, they automatically start pelvic floor physical therapy for women. So I think here we don't do that. For most patients, don't get pelvic floor physical therapy after vaginal delivery. So the chances of them developing weak pelvic floor later on in life is very, very common. So
they don't pay for it here. That's
they
the
don't
problem,
pay for it.
right?
Exactly.
They don't pay for it here.
Yeah, it's free there in Europe. Yeah.
Right.
And I don't know if I'm allowed to do this, but just a shout out to the pelvic floor physical therapists here in Center City. They are fantastic.
Yes.
Absolutely.
They're not so bad in Bluebell and out here this way either. They're great.
I just don't know them as well.
Yeah, no, but they're great in our area too.
Awesome. Yeah, feel free to shout them out. Okay, next question here. Can you please talk more about period abnormality during perimenopause? Having longer periods of time between periods, etc. So I know we talked about this a little bit, but if you could dive into those details a little bit more, I think that'd be helpful.
I mean, it's hard to say. Everybody's an individual. And so it's hard to say. And the thing is that you honestly have to talk. We always say, keep a menstrual diary, because what might be normal and might be abnormal, you really need to go over with your provider, because, if it feels like a period, that's fine, but it might not be a period. And if it's not a period, then you need to talk to a provider, because it might be abnormal. So it's really hard to say, because, they might shorten, they might lengthen. Everybody's different. So I think it's kind of hard to say what's considered normal. Sometimes people have a long period and then they stop. Some people have short periods. Everybody's different. So it's kind of hard to say what's considered normal. Everybody has their own way of ending.
Okay. Yeah, I think you kind of answered this next question here too. The only other add-on or follow-up I would have here is, how long should, and let me just make sure, how long should you try a treatment approach before you know if it's working or not?
What's that mean? I'm not sure what that means in terms of a treatment approach. I'm not sure what that means.
Yeah, that might need to be a little bit more specific. So I think overarching theme, talk to your doctor. Okay. Next question here. We talked a lot about hormone replacement therapy. Can you talk about other options for patients who may not be candidates for HRT?
Well, Dr. Jackson talked about a great new option, and there's another one coming out. And so there's a non-hormonal FDA approved option out there for people who don't fit for hormone therapy. And so again, talking to their providers, and there'll be another one out hopefully by the end of the year that's going to be competitive for that. So therefore there are other options out there. And again, finding out from there's commercials about it. It's non-hormonal, so there are other non-hormonal FDA approved.
Absolutely. Dr. Jackson, anything to add there? I know that as Dr. Fay mentioned, you did go through that earlier.
Dr. Jackson talked about it.
Yeah, I would say exactly that. There are non-hormonal options. They tend to treat just the vasomotor symptoms and not any of the other symptoms, but there are several, and we can find one that's best for each individual.
Absolutely. Okay, thank you. All right, next question here. If a patient is on a birth control and not getting a period, can they still monitor hormones as related to mood, brain fog, etc.?
So is the question that if they're on birth control, can they monitor the hormones?
If they're not getting a period.
Yeah, it's not accurate. So when you're on birth control, your hormone levels,
You can't
check.
regulate hormone. You can't check hormones. Yeah, you don't check hormones. If somebody's on an estrogen progesterone birth control pill, you don't check hormones. If they're on progesterone only, then you could check to see if they were menopausal or not, because you're just checking, you're on a progesterone only pill. So you could check to see if they were menopausal, but in terms of moods and everything else, you're not doing any blood work to check for their moods, but you could see how they're feeling. But there's no, but it's kind of a funny, it's in terms of the question, it's hard to answer the question. So, it depends. And if you're not getting a period, I guess I don't know whether they're on an estrogen progesterone pill or they're only on a progesterone pill.
And maybe a little bit tangential, but missing your period while you're on birth control pills is not a sign of menopause.
Right. It's not a sign of menopause. And it's okay, because you're just not building up the lining of the uterus. So you're not shedding it, but that's okay, because that can be normal. A 22-year-old can be on a low dose birth control pill and not shed their lining and not be menopausal.
I think that's an important call out there. So thank you. Yeah. And again, I think just another reminder to talk to your doctor, especially when it comes to kind of these specific questions. So, okay. Next question here. Can you talk more about the 10-year window?
What we have done is we've shown through studies with going through the WHI, which came out in 2001, after looking it over and realizing that the study only really looked at very few women in their early 50s. It was actually a study that really looked at women over 60, that when they evaluated the study multiple times, that there's really a safe window from your last period to 10 years out, that it is a safe window for you to be on hormone therapy. So that's the 10-year window that we now talk about. So you can start hormone therapy within that 10-year window. So if someone comes in and they are 10 years past their last period, the risks versus the benefits are high. But if you are within that 10-year window, the benefits are greater than the risks. If someone is after that 10-year window and they have remained on remained on hormone therapy, they may remain on. And that's what I was just saying, that the study most recently has come out and said, and now says. But you can't start hormone therapy. You can't start as a woman who's 62, who stopped getting her period at 48. Okay, she's past that 10-year window. She can remain on it if she started it at 48. Okay, so unfortunately, if someone walks into your office at 62 and says, I'm still hot flashing and night sweating, I never was given the option of starting, can I start now? The answer is no. But can I remain on hormone therapy because I've been on it for 12 years? The answer is, of course, you may.
Okay. Any other remarks there, Dr. Jackson or Dr. Nair?
No, I think that was a great summary.
All right.
Yeah,
Perfect.
nothing to add from my side either.
Okay. Next question here. Does everyone get hot flashes during menopause?
Answer is no.
The answer is no.
There are, yeah, several women who actually have no symptoms at all. They transition through menopause and have absolutely no symptoms. So it's very individualized. And why do some women have so much harder time? There's actually a study in Women's Health Journal that was published, and it showed that how we approach menopause makes a big difference. So among Asian women, it's revered, like the menopausal phase is supposed to be like age of, it's rebirth sort of thing. Mayan women, it's supposed to be like a phase of rebirth, and most of them don't have too many menopausal symptoms. And for us here in the US, I think for us, we look at it as the beginning of the end of the life. So I think we end up, suffering through the menopause. I think the study actually did show that US women had higher incidence of hot flashes, night sweats, and the menopausal symptoms. So there might be some, something in there in terms of, how we approach it. But each person is very different. There are many women in the US as well who have absolutely no symptoms. And there are some women who have very difficult time. Most women have a difficult time going through the menopausal phase. So you're not alone. There are many who have a difficult time going through the menopausal phase.
Yeah, that's an interesting study there. So, wow.
Mm-hmm.
All right. I guess along those lines, this next question, is there any current research being done on menopause? How can we learn more?
There's always being researched, but the problem is the Women's Health Initiative was really the big one, which was a very expensive, long study that was done. It was over a 20-year period, and it was very expensive. So there are smaller studies being taken off of that, but there are probably not going to be any others as big and as long as that one.
Okay. All right. Next question here. And again, a shout out to the audience for such terrific questions, a really engaging discussion.
Great. They're great.
Yeah. Okay. Next question. If a woman used hormones to get pregnant, is that a reason to avoid HRT?
No.
No reason. No.
Okay. All right. Well, that's good news there. All right. Do you recommend staying on the birth control pill through menopause or stopping it sooner?
I actually keep them on until 55. So they transition through, and then I test them to see if they've gone through menopause, and then transition them right into hormone therapy. So I do an age 55 and check them. So I transitioned them so they kind of easily transition right through. So I use 55.
Okay. Dr. Jackson or Dr. Nair, any?
Yeah, as long as people don't have, we had talked before about some of the reasons why people could develop a contraindication to taking birth control pills, but otherwise I agree. I mean, I usually do 52 or 53, but same concept.
Yeah, mine is usually around 51, 52. I think pretty much all of us are in that range, around that range. So 51, 52, I transitioned them to menopausal hormone therapy. Yeah.
Okay, thank you. All right, Dr. Nair, this next question is for you, as I know you brought up heart disease earlier. So could you just talk a little bit more about menopause and heart disease and cholesterol?
Yeah. So when we are younger, and this is one of the reasons why the WHI study was done, because estrogen protects the heart. It's very good for the heart. Estrogen keeps our LDL, which is the bad cholesterol, down, and it helps boost up our HDL, which is the good cholesterol. It keeps our vessels, blood vessels, very pliable, and that's what you need. That's what prevents hypertension. And when the LDL level is low, it helps prevent plaques. Plaques is what causes atherosclerosis and leads to heart disease. Now, when we, as we grow older and the estrogen level declines, the protective effect of estrogen is withdrawn and the LDL level starts to creep up. LDL is our bad cholesterol, which is the one that causes the plaques. And the protective effect of the HDL, even if you have a higher HDL level, that protective effect declines after menopause for whatever reason. So women tend to be at higher risk of developing heart attacks and strokes after menopause. Now, like I said, the WHI study was initially initiated to show that hormone replacement therapy protects women against heart disease, but it's the opposite of what they found. They found that synthetic hormones actually increase the risk of heart disease. But like I said, 70% of heart disease, the risk for heart disease, heart attacks, can be reduced with lifestyle modification in menopause. So that's the good news we have. The exercise and diet play a pivotal role. So although we have a few things against us going into menopause, there are several things we can do from our standpoint to mitigate that risk factor for us.
Okay, and definitely good news there that lifestyle changes can play a big role there.
Mm-hmm.
All right.
Yes.
Okay, and as we're wrapping up the evening, just a few more questions here. Will urgency typically subside post-menopause?
No. That's why we talk about using vaginal estrogen. We have found that we are at increased risk for urinary tract infections because of atrophy, vaginal atrophy. So we have found that using vaginal estrogen decreases the risk of urgency and also decreases the risk of urinary tract infections, which are so dangerous for older women because older women are so at increased risk. So we found that giving that little bit of vaginal estrogen has been so helpful. So therefore, we always encourage our women to use vaginal estrogen when they have vaginal atrophy. And so you'll see urologists encouraging people to do it, and we will give it to patients. Even the older woman, the woman who is now 5 years post breast cancer, we will now encourage them to use it because studies show that they are not at increased risk for a recurrence of breast cancer. We will encourage them to do it. So it actually has been beneficial for so many women. So even women who don't want to use hormone therapy, oral or transdermal, will encourage them to use it for their vaginal estrogen, for their vaginal atrophy, excuse me.
Yeah, the vaginal estrogen is just magical for many women who suffer from painful intercourse. It just plumps up the tissue, it gives the estrogen back. So, and it's very, very safe. So that's the thing, because it doesn't get absorbed much. It's locally absorbed. It doesn't get into the bloodstream much. So even for, as Dr. Fay mentioned, even for cancer patients with history of breast cancer, it's still approved for use for vaginal symptoms, including, the UTIs and the vaginal dryness and so on.
Okay, thank you. All right. This next question here, Dr. Nair, you talked about it a little bit earlier. What advice would you give patients struggling with weight gain when diet and exercise doesn't seem to be enough?
So I think, diet and exercise play a big role, but in today's day and age, we have excellent medications that help as well. But again, we always start with diet and exercise because without having that in place, it's very difficult to add the medication in there to help with weight loss. So my first step is always going through, the detailed food diary to find out how many calories they're taking in. I usually recommend sticking to around 1,300 calories per day because we need around 1,800 calories per day. If we take in 1,800 calories, we end up maintaining our weight. So in order to lose weight, we have to create a negative energy balance, which means if we take in 500 calories less than what we need, which is the 1,300 calories per day, in a week, that is 3,500 calories less than what we need. So if you take in 3,500 calories less than what you need, you lose 1 pound. So in order to lose 1 pound, we have to take in 3,500 calories less than what we need. It may not feel like a whole lot, but in a year, that's 50 plus pounds that we lose. So slow and steady is always great. So that's one of the things when I tell this to my patients, it's not too bad. And again, the first step is always to keep a food diary and see how many calories you take in. So sometimes with the exercise, we may find that we take in 2,000 calories, 2,200 calories. So going from 2,200 calories to 1,300 calories in a week is not possible. So what I tell them is go from 2,200 to 2,000 calories in 1 week, 2,000 to 1,800, 1,800 to 1,600, and slowly reduce by 200 calories per week. And in 2 months or so, you get to 1,300 calories and then stick to 1,300 calories. Again, some women may have more difficult time sticking to that 1,300 calories because there's cravings and stress can cause a lot of carb cravings and insulin resistance that happens with perimenopause and menopause makes it much harder to lose weight. That's where the medications, the weight loss medications or the insulin sensitizers come in. We have a great class of medications called GLP-1 agonists out in the market. These are the Ozempics and the Wegovys. The Ozempic is approved only for diabetes, but we have the Wegovy, which is approved for weight loss. We also have Zepbound, similar to Mounjaro, which is used for diabetes. We have Zepbound, which helps with weight loss. It's the amount of weight loss we get with these medications is astronomical. The stuff we used to get only with the bariatric surgery in the past, like 100 plus pounds of weight loss, that's what we see with these medications. So it's awesome. So I think but again, with each of these medications, you have to be careful who you use it for, and they still have to follow the diet and exercise. So diet and exercise first, but if they're still struggling, medications.
Yeah. And Dr. Fay, I see you nodding along. Anything you'd want to add there?
No. No, it's great.
Very helpful. So thank you.
Yeah.
Okay. Well, as we just about wrap up this evening, I do have one final question before we close out tonight. So for the final question this evening, what are your goals for everyone listening in on this webinar? What would you want our viewers to take away from tonight? And Dr. Jackson will go ahead and start with you.
So I think we've mentioned this several times, but what I wanted everyone to know is everyone's menopause journey is different. The best thing you can do is share your symptoms with your PCP or your gynecologist, and we can partner together to figure out if you would benefit from treatment and what treatment is best for you.
Okay. Well, thank you so much. All right, Dr. Fay, any closing remarks?
It sounds right. I mean, I just don't be afraid to educate yourself, ask questions. And remember, we're all individuals, and don't be afraid to ask questions. And you know what? And you're not in this alone. I mean, all of your friends are going through it, and, talk it out with people, and don't isolate yourself. You are not going through this alone. Ask your PCP, ask your women's health advice, your women's health physician. And if you're not satisfied, find somebody who will help you. There's always somebody who will.
Absolutely. You're not alone. A really important reminder. So thank you. Okay. And finally, Dr. Nair, any last remarks?
Sure, yeah. So as I had mentioned earlier, women spend about 30 to 40% of their life in menopause. And I think we're conditioned to think of menopause as the beginning of the end. And there's plenty of quality of life to be had during that phase. So my message would be to embrace menopause, and with a little bit of effort, we can live the best quality of life during this time. Again, there are some risk factors that come with menopause, including heart disease and osteoporosis. But with lifestyle modification, the good news is that with lifestyle modification, with diet, exercise, and smoking cessation, we can certainly reverse many of these risk factors. And for our females, our women who are going through really bad menopausal symptoms with hot flashes and night sweats, please remember that you're not alone in this battle. You don't have to suffer alone. Please reach out to your primary care providers and your gynecologist to have this discussion and to ensure that we go through a smooth menopausal transition for you.
Absolutely. All right. Well, thank you so much, Dr. Jackson, Dr. Fay, and Dr. Nair for your time this evening. I know so much great information was shared, and thank you so much to everyone for attending and submitting such great questions. I learned a ton, so I hope you did as well. We will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to also visit jeffersonhealth.org to make an appointment. Stay up to date on upcoming events and webinars just like this one and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to men's and women's health and much more. A recording of this event will be sent to you so you can rewatch at your convenience. And if there's anything anyone here at Jefferson can do for you in this time of need, please go ahead, reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Thank you.